Good evening, colleagues, and a very warm welcome to another masterclass in clinical cardiology. In these sessions, challenging and interesting cases are presented, and we learn from the master teachers of the country regarding interpretation of various signs, hemodynamics, and how to go about solving the problems. These are of great educative value, and not only the students, but all of us learn also quite a great deal from these. With that, over to you, Hari, to take this forward.
Good evening, everyone. Welcome to the seventh episode of this year of the Heart Failure Masterclass. So, this today's program we will start with a talk by the Heart Failure Society of America faculty, Dr. Noshin Rosa from the University of Pennsylvania. She will talk on cardiac myosin inhibition in hypertrophic cardiomyopathy. Then we will have the case discussion. The case will be presented from our northeast, Nigrims, Shillong, and Dr. Preeti will be presenting. And the case will be discussed by KEM Hospital, Mumbai, Dr. Ashish, Dr. Ambuj, and Dr. Agnesh. So we'll first start with the talk by Dr. Noshin. Welcome, Dr. Noshin, and we will play the recording. Please go ahead.
Hello, everyone. My thanks to the Heart Failure Association of India Heart Failure Master's Course, the Heart Failure Society of America, for this invitation to join you today to talk about one of my favorite topics, cardiac myosin inhibitors in hypertrophic cardiomyopathy. My name is Noshin Riza. I'm an assistant professor of medicine and advanced heart failure transplant and genetic cardiologist at the University of Pennsylvania. I'm a fellow of the Heart Failure Society of America, and I'm also the deputy editor of the newest Heart Failure Society of America journal, the Journal of Cardiac Failure Intersections. So without further ado, let's get started. Here are my disclosures. So during our time together today, I hope to accomplish these three learning objectives. Number one, we're going to focus on the review of symptoms and clinical presentation of patients with hypertrophic cardiomyopathy. Number two, we're going to explain how to diagnose HCM and differentiate between obstructive and non-obstructive HCM. And number three, we're going to discuss cardiac myosin inhibitors as a treatment strategy for HCM. So of course, let's start with a case. This is Miss C, and she's short of breath. She never felt like she could keep up with her peers as a child. She was diagnosed with hypertension in her 40s. Her primary care provider heard a murmur when she was in her 50s, and now she comes to see you at age 63. She's dizzy and short of breath with exertion, and she was just not sure how much of this was normal or natural with aging, so she didn't bring it to your attention until now. So this is to highlight that individuals with hypertrophic cardiomyopathy present with a range of symptoms and clinical events. The large majority of patients with HCM live normal lifespans free of major adverse cardiac events. However, the more that we are able to phenotype and learn about HCM, we're understanding the range of complications and cardiac symptoms that patients can present with. So of course, historically, the most feared complication of hypertrophic cardiomyopathy was sudden death. Thankfully, due to contemporary advances in sudden cardiac death risk prevention and risk assessment, the risk of sudden cardiac death in this patient group is lower than the actual sudden cardiac death rate of the general population. However, other clinical manifestations and other complications can still occur. Very commonly, patients with HCM will present with symptoms like dyspnea, presyncope or syncope, chest pain, palpitations, or effort intolerance. Patients can also present as their first presentation with atrial fibrillation, symptoms of heart failure, or complications of atrial fibrillation, including thromboembolism. There are multiple pathophysiologic changes that can occur in HCM that lead to this constellation of symptoms and signs, and I've listed them here on this slide. We'll talk mostly in our treatment section about left ventricular outflow tract obstruction, which is in the occurrence of a LVOT gradient in excess of 30 millimeters of mercury, either at rest or with provocation. And LVOT obstruction is present in about 70 to 75% of patients with HCM. In addition, patients with HCM experience myocardial ischemia, diastolic dysfunction, autonomic dysfunction, and mitral regurgitation, again, all working together to lead to these symptoms. We also know that hypertrophic cardiomyopathy is underdiagnosed worldwide. Here I'm showing you a world global map of essentially our estimated prevalence of hypertrophic cardiomyopathy. We estimate that over 122 countries for which we have epidemiologic estimates, accounting for 88% of the world's population. The prevalence is somewhere between 1 and 200 to 500 individuals worldwide, which would mean that 20 million people worldwide are affected with HCM. However, on the right, I'm showing you that essentially 90% of these individuals are unidentified. We've identified about 10% of these individuals with HCM clinically, 6% because they become symptomatic, and about 4% because of detection through avenues like cascade screening or family screening. At the moment, we're using essentially a one-size-fits-all diagnostic threshold in hypertrophic cardiomyopathy. Essentially, what that means is that we make the diagnosis of HCM in the setting of having an end diastolic left ventricular wall thickness in one or more myocardial segments, in adults particularly in excess of 15 millimeters or 13 millimeters in the presence of a family history of HCM and or a pathogenic or genetic variant, disease-causing genetic variant that we expect to cause HCM. And of course, these have to occur in the absence of another cause of left ventricular hypertrophy, things like neuromuscular conditions, metabolic or mitochondrial syndromes, other syndromic diseases, structural heart disease, and of course, the most common things that we experience, pressure loading conditions on the left ventricle, including hypertension and aortic stenosis. We're, of course, advancing our understanding of the genetic causes of hypertrophic cardiomyopathy as well, and moving more towards a schematic like I'm showing you here with regards to how to think about the genetic causes of left ventricular hypertrophy. So what we understand currently is that about 40% of patients with HCM or HCM probands, and the first people that present with HCM in a family, have identifiable disease-causing genetic variants. So when you see a patient with apparent hypertrophic cardiomyopathy or left ventricular hypertrophy that meets the requirements we just reviewed, we can bucket them potentially into these four conditions. Sarcomere positive HCM, which means that they have a genetic variant causative of HCM in one of the genes listed here that are associated with the sarcomere. Sarcomere associated or other monogenic HCM, again, similar disease-causing variants in the genes listed here that are not directly impacting or associated with the sarcomere, but are sarcomere associated. We can have non-sarcomere causes of left ventricular hypertrophy. These are associated largely with potentially other syndromes, as you can see listed here, like RASopathies, glycogen storage or lysosomal storage diseases, other infiltrative cardiomyopathies, muscular dystrophies, and so on. And then finally, we're learning a lot about the polygenic contributions to HCM and their future risk that we can assess with things like polygenic risk scores. So echocardiography is the pillar of HCM evaluation. We use echo to, number one, establish a diagnosis and determine the pattern of hypertrophy of the left ventricle. Number two, to evaluate global myocardial function. Number three, to establish the presence and severity of left ventricular outflow tract obstruction. Number four, to evaluate the degree and direction of mitral regurgitation if it's present, and the structure of the mitral valve apparatus and papillary muscles themselves, as this mitral valve apparatus is also often separately abnormal in HCM. And then finally, we also use echo to evaluate for left ventricular apical aneurysm. So let's return to our patient, Miss C. Here I'm showing you a representative image of her echocardiogram. And as you can see, she's experiencing systolic anterior motion of the mitral valve, as you can see there, a hypercontractile appearing left ventricle. And then when we add color Doppler, we're able to see turbulent flow in the left ventricular outflow tract, suggestive of left ventricular outflow tract obstruction there at the level of basal left ventricular septal hypertrophy and the area of this systolic anterior motion of the mitral valve, and you can also see eccentric mitral regurgitation directed along the posterior wall of the left atrium. So this looks like a very classic presentation of asymmetric left ventricular hypertrophy, left ventricular outflow tract obstruction, systolic anterior motion of the mitral valve, all consistent with hypertrophic cardiomyopathy. So when we have a patient or an individual with suspected HCM, of course, we do the diagnostics we just discussed: EKG, echocardiogram, cardiac MRI, genetic testing. We establish the presence of a phenotype and really characterize what that phenotype is. And then we complete our baseline evaluation assessment, including a sudden cardiac death risk assessment, as we discussed earlier. And we also make sure to perform stress echocardiography to really understand the complete range of functional capacity of our patients, and to also make sure that we're not missing left ventricular outflow tract obstruction that may only be elicited with provocation such as exercise. So just to briefly review, these are an excerpt from the most recent 2024 American Society guidelines for the management of hypertrophic cardiomyopathy. You can see here that if a patient has a prior event, including sudden cardiac death, ventricular fibrillation, ventricular tachycardia, of course, an ICD is recommended in that situation. If not, we have the following risk assessment factors: family history, massive left ventricular hypertrophy, unexplained syncope, apical aneurysm, or a low ejection fraction lower than 50%. In that case, we receive a 2A indication for an ICD. NSVT has been subsequently deprioritized in the sudden cardiac death risk assessment scheme. So that is another additive piece of evidence after we go through the major 5 bullet points listed above. And of course, in this day and age, we're also using the presence of late gadolinium enhancement on cardiac MRI to help us make the decision as well. So let's move on to how individuals with obstructive HCM are treated in 2025. So here I'm showing you the European Society of Cardiology guidelines next to the American ACC/AHA guidelines for the management of hypertrophic cardiomyopathy, and we'll be comparing and contrasting the treatment strategies listed in the guidelines here. So again, this is for obstructive HCM with symptoms, and as you can see, both guidelines say that if you have obstructive physiology and you think symptoms are coming from this level of obstruction, essentially the first thing to potentially consider is beta blockers. Now, the ESC guidelines specifically give beta blockers in isolation a class 1 recommendation as the first and only step. As you can see, the American guidelines provide an equivalent recommendation to beta blocker, verapamil, or diltiazem. And then on the ESC side, after beta blockers, if patients are still symptomatic or intolerant or have a contraindication of beta blockers, then the guidelines recommend moving to a non-dihydropyridine calcium channel blocker with verapamil or diltiazem. So up until very recently, there were really minimal data in a randomized controlled trial fashion telling us about the effect of metoprolol in patients with obstructive HCM. So here I'm showing you essentially the only metoprolol-specific randomized controlled trial that's been done in HCM, recently done in 2021. And this was essentially a study of crossover, giving metoprolol to patients with obstructive HCM and following their symptoms and gradients. So again, the baseline pathophysiology of the consideration of beta blockers in HCM is listed here. Beta blockers essentially decrease heart rate and contractility, thereby increasing diastolic filling, lowering LVOT gradients, decreasing symptoms, and increasing potentially maximum exercise capacity. Now, in this trial that was done, a randomized controlled crossover design of 29 patients and looking at the effect of 14 days of metoprolol treatment, the results are shown here. Patients had lower LVOT gradients at rest, peak, and peak exercise, had reduced exertional dyspnea and angina, however, no change in a maximum exercise capacity. So this gave us really, for the first time, a specific way to counsel patients about what to expect in a data-driven fashion from treatment with beta blockers for obstruction. So let's go back to our patient who's still short of breath. We started with, as the guidelines recommended, beta blockers for her, and she messaged our clinic saying she's taking the beta blocker twice a day, as we suggested. She's increasing her water intake to hydrate more, and she feels like it's made a difference. She's less winded after climbing stairs. So at this point, we decided to perform a stress echo. And here I'm showing you her electrocardiogram. You can see that her heart rate is hovering right about 60 beats a minute. And this is an excerpt from right before the stress part of the echocardiogram with just Valsalva maneuvers. And you can see that even just with Valsalva, her LVOT gradient, despite this treatment, was still about 80 millimeters of mercury, so still qualifying as severe obstruction. So what do we do from here? Well, let's return to our guidelines. Let's look at the ESC side of the guidelines. Now they say after beta blockers and non-dihydropyridine calcium channel blockers, if patients are still symptomatic, your next step would be disopyramide or mavacamten, a cardiac myosin inhibitor, either as a class 2A recommendation. And on the right side, in the American guidelines, you can see that after beta blockers and calcium channel blockers, if there are symptoms that persist, the American guidelines give essentially an equivalent recommendation to myosin inhibitors as a class 1 recommendation, disopyramide, and septal reduction therapy, essentially all in the same consideration. Now let's talk briefly about septal reduction therapies as a detour prior to our discussion about cardiac myosin inhibitors. So as a reminder, patients with obstructive HCM with advanced heart failure symptoms despite maximal medical therapy, those are the patients who are indicated to receive septal reduction therapy at an experienced center. On the left side, I've made some notes here about alcohol septal ablation, which is indicated for patients who are contraindicated to having surgery or at unacceptable surgical risk. And on the right side, we have just patients who are indicated to undergo myectomy, especially if they have other abnormalities of the cardiac structure, especially related to the mitral valve or intrinsic coronary artery disease that would also benefit from concomitant operation, or valvular aortic stenosis that would also benefit from a similar same side and same time operation. So the availability of septal reduction therapy is an important aspect of what we consider comprehensive HCM care. Here I'm briefly comparing and contrasting alcohol septal ablation and septal myectomy in terms of their procedural risk, perioperative mortality, outcomes, long-term survival, and relative advantages and disadvantages. And overall, while the procedural risks are of course different between a percutaneous procedure and an open heart cardiac surgery, mortality remains very low in the hands of experienced operators for both procedures. The outcomes generally are very high in quality for both, with a higher incidence of repeat need for procedure in the alcohol septal ablation group, but similar long-term extended survival at 5 to 10 to 15 years, again, similar 80 plus, 90 plus %. So now let's return. We have our patient. Again, we're thinking about MIS-C. We've talked about all these different options. Now let's take a zoom in on the cardiac myosin inhibitors. Now, cardiac myosin inhibitors, again, are essentially a new novel therapy for patients with HCM, the first molecularly directed therapy for this disease. And here I'm showing you a diagram essentially of where mavacamten in particular as a cardiac myosin inhibitor interacts in the chemico-mechanical phase of cardiac actin and myosin binding. So you can see there in this diagram where exactly mavacamten and aficamten, the second generation cardiac myosin inhibitor, work to slow inorganic phosphate release, which prevents the power stroke of the myosin binding to actin. And then essentially in the bottom graph, you can see that in normal sarcomere, that's an expected number of actin-myosin cross bridges as an illustrative form. And hypertrophic cardiomyopathy, we have an increased number of cross bridges leading to that increased hypercontractility, but cardiac myosin inhibition essentially decreases the number of these cross bridges, therefore returning the hypertrophic cardiomyopathy heart to more of a normal sarcomere status, reducing that contractility. Now, mavacamten has been studied in several clinical trials, so I'll spend the next few minutes just running through the major clinical trials that have led us to this current era that we're in contemporary cardiac myosin inhibitor or CMI care. Our first major phase 3 clinical trial in obstructive HCM patients of mavacamten was the Explorer HCM study. To that point had been the largest randomized controlled trial of patients with obstructive HCM. The therapy tested was mavacamten at a starting dose of 5 milligrams. The duration of the trial was 30 weeks. And I'll just show you again, very similarly throughout, but a series of primary and secondary outcomes tested in these trials. You can see that the resting and Valsalva LVOT gradients with those treated with mavacamten there in the blue line compared to those with placebo in the red line. The LVOT gradients had a rapid and sustained decline throughout the duration of the study. Again, similar story with the post-exercise LVOT gradients. In addition, the primary outcome of the trial was increase or assessment of peak oxygen consumption or peak VO2. Again, assessment of cardiofunctional capacity. And you can see again in this study, the primary endpoint was looking at either 1.5 mils per kg increase in the peak VO2 with an associated NYHA class improvement, or an increase of 3 milliliters per kilogram per minute in the peak VO2 without a worsening of NYHA class. And this was highly statistically significant between mavacamten and placebo. And then, of course, assessments in functional status as measured by the New York Heart Association scale favored mavacamten over placebo, and biomarkers assessed as well. You can see significant reduction in NT-proBNP and high sensitivity troponin with treatment with mavacamten. And importantly, mavacamten also led to improvement in health status as measured by the Kansas City Cardiomyopathy Questionnaire overall summary score. And again, you can see here, especially I like this diagram because it demonstrates the off-period treatment as well, where you can see that the health status score essentially returned to baseline or worse than baseline in the patients who essentially were withdrawn from the cardiac myosin inhibitor at the end of the treatment. Now, the next study after the Explorer trial was the Valor HCM study. Again, a study of mavacamten, and particularly this study was looking at guideline eligibility for septal reduction therapy. Essentially, what this shorter trial showed that with treatment with mavacamten, fewer patients remained eligible for septal reduction therapy. And that is shown there in the graph on the left. And on the right, you can see the improvements in patients in NYHA class by either 0, greater than 1, greater than 2 NYHA classes. Again, significant improvements in clinician-assigned NYHA class over placebo. So this led to approval of mavacamten as the first and only cardiac myosin inhibitor commercially available by global regulators in the United States and in several countries worldwide. Here I'm showing you a relevant schematic of the dosing paradigm for cardiac myosin inhibitor, this particular one in the United States. And this was provided in this capacity in what we call a REMS program, or Risk Evaluation and Mitigation Strategy program, because in the clinical trials of cardiac myosin inhibitor, and particularly mavacamten here, there was a small but important risk of decline in LV systolic function with treatment. And again, the nuances of that I'll save for another conversation, but given the risks of depression of cardiac function and systolic function and progression to potentially heart failure seen in the trial, which again was fully reversible with withdrawal of mavacamten, this paradigm was established for close surveillance in the initiation phase, as you can see here, as guided by gradients and echo assessment every 4 weeks for the first 12 weeks. And then every 12 weeks thereafter, if the patients were stable with an EF greater than 50 to 55% and abolition of gradients, the dosing paradigm was as such. So of course, this is a first-in-class drug, a lot to learn in the real world about its application, and these dosing paradigms are still under investigation as more and more patients in the real-world trials and real world get exposed to the drug. And in India, just recently, the drug maker, Bristol Myers Squibb, has launched an ongoing real-world study of mavacamten in diverse populations. Other countries in Asia have similar real-world studies, and the ROVER study is particularly to India and is slated to start recruiting very soon. So a second-in-class cardiac myosin inhibitor called aficamten, as we mentioned earlier, was studied in the Sequoia trial. And just briefly running through the data here, very similar improvements in obstructive HCM patients with increase in peak oxygen uptake, reduction in peak LVOT gradients with both REST and Valsalva, as you can see here. Similar improvement in New York Heart Association functional class, and improvement in Kansas City Cardiomyopathy Questionnaire scores, so health status as well. And then just really hot off the press here, just last week at the European Society of Cardiology meeting in Madrid, there was the MAPLE HCM trial, which was aficamten versus metoprolol monotherapy in patients with obstructive HCM. And in this trial, aficamten was superior to metoprolol monotherapy across these endpoints, in particular, again, peak oxygen uptake, reduction of LVOT gradients at rest and Valsalva, very similar to what we saw before, and biomarkers and cardiac structure remodeling, as you can see here with left atrial volume index over time. So again, a lot of great rich data to help us now really guide our patients and potentially move towards a world in which we can start cardiac myosin inhibitors without background therapy with beta blockers. So more to come in this space for sure. And then finally, again, similar changes with aficamten and improvements in health status and NYHA class. So overall, although the clinical trials were done in slightly different populations, different durations, and they're not directly comparable head-to-head, I've made this very simple diagram to help us understand that essentially mavacamten and aficamten have similar efficacy and safety across their specific trials. The major differences are essentially the top two rows of the table here, their half-life, with aficamten having a shorter half-life, and the presence or lack thereof of metabolism through the CYP or CYP system. Mavacamten relies on that enzymatic pathway where aficamten does not. Their benefits and their efficacy, as you can see, very similar throughout as we reviewed. Reduction in gradients, improvement in cardiac performance, reduction in biomarkers, improvement in health status, improvement in symptoms, and evidence of positive cardiac remodeling with decreased wall thickness, improved diastolic function, improved hypercontractility, and potentially reductions in myocardial fibrosis, although these structural changes were seen in imaging sub-studies. So again, a lot more to come with extended term follow-up. And of course, there's a lot to learn in the real world with regards to how we treat patients, what the optimal dosing strategy is, the evolving monitoring requirements, of course, patient selection, long-term effects, and cost and coverage and access. So still a lot to learn. And then finally, just a note about what we know about cardiac myosin inhibition and non-obstructive HCM. Again, just really hot off the press here, presented at the ESC meeting just a couple of weeks ago, the Odyssey HCM trial and published in the New England Journal of Medicine. This was a study of mavacamten in a phase 3 randomized controlled trial, the largest trial of patients with HCM to date. Again, this is symptomatic non-obstructive HCM, and in this trial, mavacamten did not improve peak VO2 or symptoms related to HCM compared to placebo. So while it works in a really remarkable way for obstructive HCM, we haven't yet quite found the mark with mavacamten in non-obstructive HCM, but again, a lot, I'm sure, to come from different analyses of these clinical trial data. So that brings us to our end of our whirlwind tour of HCM. So hopefully we've accomplished learning the symptoms and clinical presentation of HCM. We've learned how to diagnose and differentiate between obstructive and non-obstructive HCM. And we spent some time discussing cardiac myosin inhibition as a treatment strategy for HCM. So our take-home points is that HCM is underdiagnosed. Patients present with a variety of signs and symptoms, so disease awareness is key. Echocardiography is integral to the diagnosis of HCM, and stress echo is underutilized but should be performed in everyone to confirm the presence or absence of provocable LVOT obstruction. Cardiac myosin inhibitors are safe and effective for obstructive HCM and offer improvement in symptoms and functional status, potentially positive cardiac remodeling as well, but longer-term data are definitely needed. And cardiac myosin inhibitor, again, just hot off the presses, has not definitively shown benefit in non-obstructive HCM, but we are awaiting future trials of aficamten in a non-obstructive HCM population. That's the Acacia HCM study, sarcomere modulators, and gene therapies also to come in this population. Thank you very much.
Thank you, Dr. Nushin, for that wonderful presentation. Can we have one or two questions and comments?
Yeah.
Dr. Nushin, can you hear us?
Yes, I can.
Yeah, Dr. Noshin, thanks for a wonderful presentation. One question. Now, based on the data of Maple HCM, which was presented, are you ready to discard beta blockers as the first line of treatment, as was mentioned, I think, in the discussion after the trial?
Yeah, it's a really great question. So I'll tell you, before this study with aficamten, our practice, we essentially really follow the clinical trial data, and we have over 200 patients in the real world on mavacamten at the moment. And our strategy has been to start mavacamten, as was done in the clinical trials, on their background therapy, whether that's beta blocker or their calcium channel blocker. Now knowing, of course, the powerful negative inotropic effects, the intended effects of mavacamten in some patients on dual therapy with beta blocker, calcium channel blocker, we will reduce the dose or take away one of those therapies so that patients are not on beta blocker, calcium channel blocker, and mavacamten, because then we can get into trouble with LV systolic function issues and of course fatigue and symptoms and things like that. So typically if people are on beta blocker, calcium channel blocker, we'll decrease the calcium channel blocker, leave them on beta blocker, and then add aficamten. If we do the same sort of cross titration for patients on, for example, beta blocker disopyramide or calcium channel blocker disopyramide, we'll wean them off the disopyramide and then ramp up the mavacamten. We have yet not, because these data were just presented and it's with aficamten and it was not done with mavacamten. We have not yet only started mavacamten as a primary treatment without background therapy, except in very select individuals who we have some data from other real-world studies done by the sponsor that the drug metabolism may be really powerful in those individuals. So, for example, there are some data in sort of a pooled real world experience that we have access to that, for example, Asian individuals, and this is again related to the CYP metabolism system, especially sort of petite women who are of East Asian background, may metabolize the drug in a slower way. So therefore, the mavacamten drug effect their body sees is much higher. So in those individuals, we may start at the 2.5 milligram dose, we have a couple of patients who didn't even really tolerate background therapy before. So in those very select cases, we have done no background therapy, no beta blocker, no calcium channel blocker, and then low dose mavacamten. But again, that's on an individual case-by-case basis. That's not the approach that we're taking broadly now. I think ultimately, we anticipate that aficamten will get regulatory approval, and so that if and when it does become a next-in-class available therapy, it does seem like the data obviously reflect that we'll be able to just start aficamten as a first-line therapy without having to need beta blocker, calcium channel blocker background.
Thank you.
I see some questions in the chat I'm happy to answer. So we have for Miss C with symptoms on maximally tolerated beta blocker therapy, would you add disopyramide before considering mavacamten or go right straight to cardiac myosin inhibitor? I think based on what I reviewed at least in the American guidelines, we have the sort of similar class recommendation for disopyramide, mavacamten, central reduction therapy. And so on our practice, I will say the use of disopyramide has really sort of fallen off. We're not using it as much now that we have mavacamten, again, because this is a molecularly target therapy with all the benefits that we reviewed. Disopyramide is a very powerful negative inotrope, but it can be pro-arrhythmic. It has significant side effects in certain populations like constipation and other things that we often have to also mitigate and treat against. So obviously cardiac myosin inhibition avoids all those things. So in our practice, that's sort of the sequence that we're taking. All right, and then all great questions. During treatment with this drug, how do you manage beta blockers? Yeah, great question. We published a little bit about this in our initial 36-week real-world experience that was published in JACC Heart Failure now, hard to believe, a couple of years ago. We have work in publication phase on our longer-term extended follow-up of 108 weeks, but in these papers, we describe this exact strategy because we know that it's not really described well in the clinical trial data. But essentially what we're doing is if beta blockers for that specific patient are only being used to treat LVOT obstruction, so the patient has no other indication to be on beta blocker, we are essentially weaning off the beta blocker once the mavacamten is in steady state and the gradients have been reduced, LVOT or LV function is stable, and patients generally in that case are feeling better because they're eliminating the sort of side effects of beta blockers. For patients, though, who have a reason to be on a beta blocker, like they had atrial fibrillation or they had some previous history of CAD or something, and we don't want to decrease the beta blocker, then we may consider lowering the dose to the minimally effective dose, or whatever we think will suppress the rhythm issue. But generally, we're not taking those patients off the beta blocker. So again, it's really we're weaning off, and that essentially is the same case for the calcium channel blockers as well. So for the patients again that don't have another indication to be on beta blocker, calcium channel blocker, we are trying to wean it off once we achieve therapeutic effect and gradient suppression with the mavacamten. During trial, the patients who had the fall in EF, what was the rate of recovery? And was it full recovery or decrement on mavacamten? Yeah, great question. So those patients who had the decrease in systolic function in these cardiac myosin inhibitor trials, all of them were reversible with withdrawal of the drug. So nobody remained no LVEFs remained suppressed or had systolic dysfunction after withdrawal of the drug. So it's fully reversible and full recovery, essentially, to the range that it was. Any variable or tests like troponin or BNP that can predict the decline in EF other than echo? Yeah, that's a great question. There are ongoing real-world analyses trying to look at predictors of response or predictors of LV function decline. I'll tell you anecdotally, in our clinical population, one of the things that we really pay attention to is the presence of pre-existing left bundle branch block. Again, this is not rooted in data yet, but we're trying to gather it takes a big population to gather the number of events and obviously these different predictors. But we've noticed that we have to be particularly careful in those with the left bundle. Again, they obviously don't have normal conduction disease, or they don't have normal conduction at baseline. So that's a population that we've watched. And then in the trials, and then also reflected in the real world experience, the presence and occurrence of new AFib or rapid AFib can trigger the reduction in EF. So we're very aggressive with atrial fibrillation rhythm control. As you all know, atrial fibrillation occurs at a higher rate in patients with HCM. Anyway, so it's a very common cardiac complication of the HCM pathway. So when it occurs, we're very aggressive about achieving rhythm control with antiarrhythmics or ablation so that patients can continue on mavacamten, because again, in the trials in the real world, we see when patients are on cardiac myosin inhibitor, they go into uncontrolled AFib, rapid AFib, new AFib. That's when their ejection fraction tends to decline, and then we can get into trouble. Any contraindications for myosin inhibitors? Yeah, it's a great question. In the clinical trials, a few populations were excluded, specifically those, like I was just mentioning, who had really recent AFib, really recent ventricular arrhythmia, recent syncope, sort of, anything that clinically sounds really bad until a stabilization period or you understood the cause. They also excluded individuals in the early trials with obstructive coronary artery disease, because the thought was that, if they're high risk for CAD events, let's say that unfortunately, somebody has an MI, they're on this very powerful negative inotrope myosin inhibitor, they would not be able to have a hypercontractile response in the situation of an MI. So then they would obviously go into cardiogenic shock, that kind of thing. In the real world, we are still very mindful of all of those clinical trial exclusion criteria, but it is the real world. We see patients, obviously, especially in the US, with a lot of cardiokidney metabolic disease, high rates of CAD, high rates of obesity, these risk factors. So we've had to offer the therapy to these people. And luckily, at least in our experience, we've had no issues. We've had no patients on, with MIs on cardiac myosin inhibitor, those sorts of things. Essentially the contraindications are pregnancy and unfortunately, actually a couple of times, because this happens, even though we for women of childbearing age, we have rules specifically about contraception while you're on therapy. Things happen. We've had a couple of patients actually get pregnant on mavacamten. It is known to be at least teratogenic in animal studies. And so for humans, we are obviously off. We say that we don't know the safety, and so people should not be on it. The same thing goes for men. So men should not be planning to expand or grow their families, trying to have children while they're on mavacamten. You have to be off of it for at least 4 months prior to. But we actually have had one patient, male patient, have a healthy child while he was on mavacamten. Again, these things happen in the real world. So all things that we're monitoring, but those things in particular. Let's see. Most preferred beta blocker in HCM and maximum dose of beta blocker in HCM. This is a great question. I think worldwide, various expert consensus statements and things really go with metoprolol as the first line beta blocker. Other ones that we sometimes use, although to our knowledge of little sort of lesser effect, but atenolol is used sometimes in our older population because of the issues with the blood-brain barrier, fewer side effects. And obviously things like carvedilol we stay away from because of the afterload reducing capabilities of that beta blocker in particular, which goes counter to what we'd want to do with HCM. The maximum dose really is sort of really patient specific. We have patients with 50 milligrams, their heart rate is suppressed to 60, less than 60 beats a minute, and they feel very fatigued. We have patients who make it all the way up to 200 milligrams a day, and that's what it takes to suppress their gradient. So it's really patient specific, I would say. We did talk about the issues with female patients in their reproductive phase, and it's a really great question. So for patients who, and we have this discussion obviously before we start mavacamten, and obviously if individuals are considering family planning sometime in the future, it's not a therapy that is available to them. So we proceed either with other medical therapies or potentially septal reduction therapy to facilitate their ability to have families. For people that are on mavacamten but then want to grow their families, we do essentially a wean-off period and then titrate up another therapy. So for example, coming off of a mavacamten and back on disopyramide or something, or beta blocker, calcium channel blocker, with the knowledge that they may feel more poorly than they felt on mavacamten, but obviously everything is sort of a choice and a trade-off. Or again, proceeding to septal reduction therapy for that definitive reduction in LVOT gradient, if that's what the patient's preference is. Any significant QT prolongation noted as adverse effect in any of the studies, especially in those arrhythmogenic substrates of HCM? It's a great question. We know that QT can prolong. It's something we monitor. In our real world, and to my knowledge, in the clinical trials, we haven't had any major issues that stem from QT prolongation in terms of ventricular arrhythmias. We have published on early AFib in our real world patients with mavacamten, and there are subsequently larger studies I know in process or planned to come out with larger cohorts we published on our initial experience at Penn. And essentially what we found is there is, in the real world, at least in our patient population, a higher incidence of new AFib and recurrent AFib. Again, that with aggressive monitoring can be controlled and patients can continue with therapy. And so there is some thought that there is some arrhythmogenic component, at least when we're talking about atrial arrhythmias with cardiac myosin inhibitors. The ventricular arrhythmias are harder to sort out, and patients obviously in the real world don't get continuous rhythm monitoring unless they already have, for example, ICD or cardiac implantable device in place. And so we're really in the phase of learning in the real world about, are there more PVCs? Are there more other types of arrhythmias that occur in patients on mavacamten? Or actually, is it the reverse? Is it because the afterload on the ventricle, the LVOT gradient is suppressed, the ventricle is in a more favorable pathophysiologic state? Do the triggers for arrhythmias actually get better? And, anecdotally in our early cardiac monitors that we did for surveillance in our CMI population, we noticed actually PVCs really declined and arrhythmias really declined, telling us pathophysiologically, again, this may be favorable from a rhythm standpoint. But again, I think a lot to learn whether it's pro-arrhythmogenic in some people or can help relieve arrhythmias in some other people. Should NT-proBNP be monitored to see if early systolic dysfunction deterioration, if a baseline NT-pro is already done? It's a great question. It has not been formally studied. You saw in some of the trials that I showed, they did track NT-proBNP as sort of a marker of therapeutic response throughout the trial. But there are, to my knowledge, are no published data regarding the small percentage of patients, in the trials ranging from 5 to 8% of those who dropped their EF, what their NT-proBNPs did. And the concept of NT-proBNP in HCM is also a little bit challenging because it's really not And we think about the hormone released in the setting of wall stretch or stretch, you have a thick ventricle. Laplace's law really applies a little bit differently when you have a thick concentric or hypertrophied ventricle as opposed to like a dilated ventricle and how we think about the NT-proBNP release in that kind of ventricle. So we know that patients with HCM can have elevated NT-proBNPs. We know it's an adverse prognostic sign. We don't have specific thresholds in terms of risk, the same way that we know sort of quartiles, tertiles, and DCM. And then we also haven't been able to sort of look at exactly this question, like if tracking NT-proBNP serially, for example, when we do echoes, will be predictive of anything. But it's certainly a great question and idea for future studies. And then finally, our last question looks like treatment for symptomatic non-obstructive HCM. It's a great question. And obviously, many of us were hoping that the CMIs would show similar efficacy and safety in this population. So we have one trial that unfortunately didn't show that that was the case, but I suspect we will have subsequent sub-studies from Odyssey come out, potentially identifying patient responders. And as I mentioned, the aficamten in a non-obstructive HCM trial, Acacia is still enrolling, still ongoing. So that will report hopefully in the next year, and we'll see the results of that. In addition, we have ongoing clinical trials of SGLT1/2 inhibition, so sotagliflozin in non-obstructive HCM, with endpoints looking at health status measured by KCCQ and VO2. That's a trial being done, sponsored by the United States National Institutes of Health and this drug sponsor. So we're going to sort of see if SGLT inhibition works in non-obstructive HCM. There's actually gene therapy trials happening in non-obstructive HCM, specifically myosin-binding protein C3, not severe non-obstructive HCM. And this is, again, gene therapy, so adeno-associated viral vectors with the gene product delivered to the cardiomyocyte. And early data from the first-in-human clinical trials that have been reported have been favorable, showing that the transcripts are present in a higher quantity. So the gene therapy is getting to the endomyocardium. This is proven by biopsies and doing analysis on that. And then other endpoints in the study are serially going to be reported. I think more results are to come at the upcoming American Heart Association meeting in the United States. So that's myosin inhibition, that's SGLT2 inhibitors. I think that's gene therapy. And then we return to, again, what the guidelines say, which is really, unfortunately, not a whole ton for our symptomatic patients. It's diuretics to reduce filling pressures. So we use loop diuretics. We use mineralocorticoid receptor antagonists actually a lot in our practice. So MRAs to, again, to improve diastolic function. If the patients are really presenting with elevated filling pressures, that sense of dyspnea on exertion. You can use beta blockers, but really they don't really help that much in our experience. But beta blockers for that potential angina, palpitations, chest pain component, beta blocker, a calcium channel blocker. And that's really all we have right now. So we really need more clinical trials. We need a lot more evidence in this space for these patients. But again, it is a space with a lot of ongoing investigation. Hopefully I answered all those questions in the chat. I'm happy to take more, but I know we're already over time. So I'm happy to certainly stop here. And my thanks to Dr. Venugopal, Hari Krishnan, Ahmad, and Gopalakrishna for the coordination of the course and the invitation. Hopefully this was helpful. And I'd love to meet you anytime that we cross paths at various conferences or otherwise.
Thank you, Dr. Nasheen. It was fabulous for you to have joined and answered all the live questions, and the delegates have, all of us have learned a lot. Thank you, Dr. Nasheen, and we go to the next part of our program today. It's my pleasure to call upon our examiners, Dr. Jagan Mohan Taragan, Dr. Dayasagar Rao, Dr. Ajay Mahajan, and Dr. Amit Malviya to take the case presentation and discussion forward. May I call upon Dr. Preeti from Negrum, Shillong to share her slides and be ready for the case presentation. Dr. Ashish, Dr. Ambuj, and Dr. Yaknesh from KEM Hospital, Mumbai. Please turn the video on and be ready for as the student time. Over to the examiners.
Please get started. Start with the case
So-
presentation, Dr. Preeti.
Yes, sir.
Your slides are visible, Dr. Preeti. Please turn your microphone on and start. It's
Yes,
on.
sir. Am I audible, sir?
Very well.
Yes.
Good evening, teachers. My patient, she is a 42-year-old female from Arunachal Pradesh, who is a homemaker, who presented with complaints of dyspnea on exertion for the past 10 years, palpitations for the past 2 years, and fatigue for the past 2 years. History of presenting illness, a patient was asymptomatic 10 years back, following which she developed dyspnea on exertion, suggestive of a New York Heart Association class 2, and she remained in class 2 for 8 years. After that, she developed dyspnea on doing routine household activities for 2 years, suggestive of class 3 New York Heart Association. She also gives history of paroxysmal nocturnal dyspnea for 1 year and history of orthopnea for 6 months. For the above complaints, she took medical advice 1 year back, following which they started her on oral medications, which she tells increased her urine output, and she improved symptomatically. He also gives history of palpitations for the past 2 years, which was initially associated with exertion, which was gradual in onset and gradual in offset, and it was relieved by rest. Now, for the past 6 months, she also gives history of palpitations even during the rest, more while lying down on the bed. She is able to feel the palpitations more. No history of any syncope, no history of any post-palpitational diuresis, no history of any chest pain, sweating, or neck pulsations. She gives history of fatigue for the past 2 years. No history of any swelling of legs, abdominal distension, facial swelling, or decreased urine output. No history of any abnormal body movements or rash, skin rash. No history of any fever, joint pain, hematuria, or weakness of limbs. No history of any change in character of voice, dysphagia, or hemoptysis. Past history for the above complaint, she was evaluated and found to have a heart disease and was advised to undergo surgery 1 year back. She is currently on oral medications for the past 1 year. No history suggestive of acute rheumatic fever or penicillin prophylaxis in the past. No history of any hospitalizations in the past. No history of any other medical disorders. Personal history, she has not gone to school. She does not consume alcohol or smoke. Her bowel and bladder habits are normal. Sleep pattern has been normal for the past 6 months. However, she continues to use 2 pillows during the night time for sleeping. Menstrual history, her last menstrual period was on August 23rd, regular cycles. She got married at 17 years of age, and then her first childbirth was at 18 years of age, that is 24 years back. She reports no symptoms during the pregnancy. All 5 children were home delivery. The last childbirth is 12 years back. Family history, no family history of any heart disease or sudden cardiac death. And socioeconomic history, she belongs to a lower socioeconomic status. Summary, 42-year-old female who presented with dyspnea for the past 10 years, which was insidious in onset and gradually progressed from New York Heart Association class 2 to class 4, currently in class 4 for the past 6 months. And also, she also gives history of palpitations and fatigue for the past 2 years.
Okay, so you can tell us what's your interpretation of the history. Don't repeat the history, just interpretation.
So, she has features of dyspnea on exertion, sir, probably, and also which probably it is due to some left-sided heart involvement, sir. And also she also gives history of palpitations, which is suggestive of volume overload, sir. And also history of fatigue, which is probably because of a decreased cardiac output status, sir.
Okay, so, but why do you think palpitation follows dyspnea? Usually, if it is volume overload, patients become symptomatic with palpitation, no? Initially, and then only subsequently to dyspnea. Why do you think this patient has been having dyspnea for 10 years and really not progressive, fairly stable for 8 years? What kind of history is that? You get my point. Now, what is the reason the patient has dyspnea? According to you, basically 2 reasons. Can you tell us? Broadly, not conditions, reasons for physiology or pathophysiology of dyspnea. Only 2 reasons, 2 conditions.
Due to pulmonary venous hypertension, sir.
No?
Due to pulmonary venous hypertension.
Correct. One is pulmonary venous hypertension. Correct, isn't it? Yes. And second, in the
And
absence of pulmonary venous hypertension,
so
pulmonary artery hypertension.
right? Pulmonary artery hypertension also presents with dyspnea, syncope, heart failure, but more symptoms of left heart side disease. Now, here, fortunately for you, you can rule out isolated pulmonary artery hypertension because patient has subsequently orthopneas and PNDs, isn't it?
Yes, sir.
So that gives you a clue that it is a left heart disease progressing probably to right heart disease. We do not know because he doesn't have any symptoms of right heart failure as such. Okay, then you said family history. What are the things which come to your mind when if there was a family history? What were the conditions you would like to exclude by asking about family history of sudden death and family history of heart disease? Broadly,
sir, hypertrophic cardiomyopathy can run in families, sir. So they can be
hypertrophic cardiomyopathy. We talked about 45 minutes today, but yes,
even dilated
cardiomyopathies are genetically isn't it transmitted? Correct. Then second, it's sudden death also. Generally, yes, cardiomyopathies and channelopathies. These are the two things which come as they're not really called congenital because they're called hereditary because they manifest later in life, isn't it? So they have the inherent mutations right from birth. Okay. And lastly, I would just like to ask you more thing. What do you think is the cause of palpitation?
Sir, the history which he gives is
you just said that it is volume overload, but then I had a little difficulty in accepting volume overload because if it was a primary volume overload condition, palpitation should have preceded this. And you said in the last few months the palpitation has been at rest and that has been causing her worsening of symptoms, isn't it?
Yes,
Did you
sir.
say that?
Yes, sir. Even she said that even during lying down, she feels that her heart is beating fast, sir.
Oh no, did you say that it also worsens her symptoms? No.
No, sir. No, it has not worsened.
Oh, it doesn't. Okay.
No,
That's fair enough. So you think it is a hemodynamic cause for palpitation and not an arrhythmic cause. That's what you think?
Yes, sir.
Okay. Anything else, Doctor? There's Could you?
No.
History. Yeah.
Am I audible?
Yes, sir.
Okay. I think basically she has a left heart disease and gradual onset progressive. And she now got fatigue as well. So it is leading to a low cardiac output state. There is pulmonary venous congestion. And somebody has advised surgery. So it is a correctable disease. And correctable disease and then left heart disease, more likely to be a valvular heart disease. Unlikely to be any coronary artery disease. She has gone through the 4 pregnancies. So it's unlikely that she had any serious problem during the last 4 pregnancies. If at all she has, she must have had some sort of a regurgitant lesions, which is well tolerated during pregnancy because of marked decrease in the systemic vascular resistance. So basically, in our country, probably the commonest cause, without knowing the further about the physical examination, we can only say fair to say that probably she has a valvular heart disease affecting the left side of the heart. Probably with some volume overloaded, which can be either an MR or a aortic regurgitation. But both MR and aortic regurgitation, PND and orthopnea occur quite late. She had PND and orthopnea. How long ago was that? I'm not sure.
Only 6 months. 6 months. Orthopnea last few months.
Okay. So it is occurred much later. Yeah. So that is my interpretation of the things. So can we have the physical findings so that we can...
Yeah, I think so. Yeah, that's right.
Yes, sir. General examination. Patient is conscious, oriented to time, place, and person. She is thin-built, BMI of 20.6 kg per meter square. No pallor, ictus, cyanosis, clubbing, or pedal edema. Back and spine are normal. Weight is 47 kgs, height is 151 centimeters. Coming to the vitals, temperature is normal. Pulse is 80 per minute, high volume pulse, no specific character, no radioradial or radiofemoral delay. Condition of vessel wall is normal. All peripheral pulses were well felt. Blood pressure, right upper limb was 106 by 55 millimeters of mercury. Left upper limb was 100 by 60 millimeters of mercury. Right lower limb was 138 by 60 millimeters of mercury. The health sign was positive. No other peripheral signs of aortic regurgitation were seen. Respiration is thoraco-abdominal and the rate is 13 per minute. JVP is pulsatile. It is 9 centimeter. The A wave is prominent with normal descent and normal variation with respiration. Coming to the cardiovascular system examination.
Sorry, can you just tell me what about the JVP? Was the mean JVP elevated or?
Yes, sir. JVP is elevated, sir. 9 centimeters. A wave is prominent.
From the sternal angle or 9 centimeters as?
Sir, no, sir. It was 4 centimeters from the sternal angle, so 5 centimeter I added, so total 9
so
centimeters.
that's good. So you expected the RA pressures to be 9 centimeters of water.
Yes, sir.
Okay.
No, JVP expressed in the absolute levels, whatever reference point you take it, whether it is sternal angle or above the clavicle, depending upon the position. If it is sitting position, then you say so many centimeters above the clavicle. If it is at a horizontal level, or a 60 degrees or whatever it is, you just express it so many centimeters above the sternal angle. This 9 centimeters is calculation. You are expressed, what you have written down there is JVP. You are not written down as RA pressure.
Yes.
Okay, go ahead.
Interpretation of the RA pressure, that's correct. But was a Gilloway pressure seen in sitting position? Probably that is the best way to look at it. If it is well seen in the sitting position and with the mean at the clavicle, then certainly we know the JVP is elevated and the right atrial pressure is more than 7 millimeters of mercury, isn't it?
No, what exactly you mean by normal variation with respiration? Could you just elaborate on that?
Yeah.
So the jugular venous pressure during inspiration, normally the jugular venous pressure, it comes down, sir.
Mm-hmm. So
Yes.
Okay, go ahead. How often have you seen a patient with heart failure with such a wide pulse pressure?
Sir, very rare, sir.
Very rare. So what does that indicate?
Probably there is a multivalvular disease, sir.
You mean mitral stenosis?
Could be a mitral stenosis.
No. What does the pulse pressure really represent?
It's a wide pulse pressure, sir.
No. What does the pulse pressure hemodynamically represents? What does it represent?
Here it shows that the systemic vascular resistance is low, sir.
No, that is not correct. Pulse pressure represents only the stroke volume and the compliance of the vessel wall. So that the point here is, if a patient is in heart failure, by and large, your stroke volume is reduced, cardiac output is reduced. So you expect the pulse pressure to be normal or less than normal, not higher than normal. If it is higher than normal, there are only 2 or 3 possibilities, which includes 1, 2, 3. Tell us.
Aortic regurgitation, sir.
No, in the absence of a valvular heart disease.
Associated anemia.
Mm-hmm. You said there is no balance.
Anemia, somebody had asked about anemia. Yeah, good.
Anything else? Do you consider high output failure?
Yes, sir.
Like?
Anemia, thyrotoxicosis, beriberi.
Okay, so it is important that, is it important to differentiate between a high output failure and then a classical low output failure?
Yes, sir.
How does it matter?
The management differs, sir.
Yeah, what is the difference in the management?
So correct, high output failure, the correction of the etiology will improve the heart failure, sir. Whereas in the others, we have to give heart failure medications, which then only will improve the heart failure, sir.
Yeah.
Okay, go ahead.
Yes. Cardiovascular system examination, inspection, the chest is symmetrical. Apical impulse is seen in the left 6th intercostal space, 1 centimeter lateral to the midclavicular line. No visible scars, sinuses, or pulsations. Palpation, the inspective findings were confirmed. Apical impulse was palpated in the left 6th intercostal space, 1 centimeter lateral to the midclavicular line. It is diffuse, hyperdynamic in nature, and LV type of apex. A diastolic thrill was also palpated in the mitral area. The P2 is palpable, a left parasternal heave of grade 2. Auscultation, S1 is loud, the S2, A2 is soft, P2 is loud, no S3 or S4. Opening snap is present in the mitral area. Coming to the murmurs.
Just 1 minute, please. Go to the previous slide. Don't see physical findings. You should go a little slowly so that we can also, palpation. I think we got it all right. Go to the next. Auscultation.
S1 is loud.
Yeah.
Coming to the S2, A2 is soft. The P2 is loud. No S3 or S4. Opening snap is present in the mitral area.
What is the nature of the split? You didn't mention anything about split.
Sir, split, actually, I couldn't make out. The A2 was very soft, sir.
No, you have written down as though you have heard both components.
Yes.
A2 soft, P2 loud. So obviously you have heard the two components. So it is mandatory that you describe the nature of the split. Otherwise you write down as S2, split not audible. You can't be writing two components and then can't say that there is the pattern of the split. Okay. Second thing is you have written down opening snap present in the mitral area. What else is important? Opening snap. What is the interval between the opening snap and the second sound? Is it close or very wide?
So because the A2 was actually soft, so I was not able to actually make out the A2 AS gap, sir.
That's a good point. Yeah.
So what is the implication of a soft A2?
Sir, soft A2 means the aortic valves are not able to move properly and not able to, thereby not creating a sound to generate an A2, sir. Either the valve is calcified or is immobile.
Immobile. Or the valve is not there at all.
So do you suspect that it could be due to aortic stenosis or only isolated aortic regurgitation?
No, she has not mentioned anything to suggest aortic regurgitation so far.
She had features of aortic runoff here, she had said, no?
No. She said Hill sign is positive. No other signs of regurgitation are presented.
Wide pulse pressure with a low diastolic pressure. So she did say, so now only thing is because now P2, generally pure aortic regurgitation, the A2 is well preserved.
No, second thing is, it is very contradictory that you said there is a mitral diastolic thrill, opening snap. Do you expect a S3 and S4 to be present?
No, sir.
Then why have you written it down? That means you don't understand the conditions required for S3 and S4.
Yeah, it doesn't matter, just for completion, but probably not. Maybe
it doesn't.
You wouldn't hear S3 and S4 in significant mitral stenosis. That's what Sir is telling you.
Yeah.
No, sir, we don't get an S3 and S4.
Yeah, good.
No, can you get it from
good,
the
as
right
long as
side?
you understand it. It's fair enough.
No. Can you get it from the right side?
From the right side, we can get, sir.
So your answer should be no S3 and S4.
S3 and S4 is not possible, sir, but
left side S3 and S4. Okay.
Yeah. Okay.
Yeah, good. And it's a good point.
No.
Anyway, but there are no other murmurs, huh?
No.
Oh, yeah, you're not yet come to the murmurs. Let's see the murmurs. Yeah. Come to the murmurs.
Mitral area, a low-pitched, rumbling, long mid-diastolic murmur of grade 4 with pre-systolic accentuation, best heard with the bell of the stethoscope in the left lateral position. Neo-aortic area, a high-pitched, blowing, early diastolic decrescendo murmur of grade 3, heard in the left third intercostal space close to the sternum, best heard with the diaphragm of the stethoscope on sitting and leaning forward position.
You told everything except the most important thing. Neo-aortic area. What is the length of the murmur?
Sir, it is only it involved only the early part of the diastole, sir. It was not holodiastolic, sir.
No. You said neo-aortic area. You said early diastolic, decrescendo murmur. Is it a short early diastolic or a long diastolic?
It's a short early diastolic, sir.
You understand the implication of the length of the murmur?
Yes, sir.
What does that mean?
Sir, the length increase in the length of the murmur implicates that the AR is severe, sir.
Okay. So length of the murmur is proportional to the severity.
In chronic AR, length of the murmur
Yeah.
generally goes with the severity of AR. In acute AR, you may get a short or not even get a murmur. Good, that's right.
Okay,
So
now
you got a high pitch blowing airway diastolic murmur, and any in the other aortic area, any ejection murmur?
Sir, no, sir.
No.
No, sir.
Okay.
now in a patient with aortic regurgitation, what is the importance of A2? Suppose if the AR is there with a loud A2 compared to AR with a soft A2.
Sir, AR is there with the loud A2 means it is probably a non-rheumatic etiology, sir.
Non-rheumatic etiology.
Yes, sir.
Usually
Probably a
associated with
bicuspid
an
aortic
aortopathy.
A2,
or there is a vascular involvement, sir.
yeah, that's what you know. The problem here is aortic regurgitation can be due to valvular or vascular. That is, aortic root is dilated.
Yes, sir.
And the leaflets are normal. So it gives you a loud A2, something like a timbre quality.
Yes.
Whereas if it is a valvular AR, the A2 will be soft or probably may not be heard also in some patients.
Yes, sir.
So from the description of the murmur, what
Yes.
do you think is the most likely valvular heart disease here?
Sir,
You
most
said
likely.
the AR is only mild.
Yes,
You are
sir.
giving an impression that MS is the severe one.
Yes, sir.
So MS tight and AR mild, giving a high pulse pressure.
Sir, probably the MS is severe. It is masking the effect of the distal lesion, sir.
No, effect
That's why
of the
the AR is.
No,
Yeah, how
no,
does it mask? Can you just tell us how does a severe obstructive lesion proximally alter the features, the clinical features of aortic regurgitation?
Sir,
Yeah, good.
because of the severe MS, the preload is also low, sir. So
Yes.
that way the AR is also, the severity of AR probably is, the MS is misleading that the AR is less severe, sir.
There's a limitation with stroke volume. Isn't it? Preload is
Yes, sir.
decreased, so AR findings could be underassessed.
Underestimated.
Okay.
No, that is the very
So will
reason
that
I
explain
said
your blood pressure of just 110 by 50?
50. Yeah.
Or you think it is something else in addition? What are the reasons where you get a cutoff of systolic pressure in AR? Just 2 or 3? One we said anyway, mitral stenosis. Any other?
Associated aortic stenosis, sir.
Very good. And third?
In failure, sir, if the patient is having LV dysfunction.
Correct. Very good. If there is LV dysfunction, or of course acute AR, which we are not considering here. These are the 4 reasons you may not get a very high systolic pressure in AR. Good.
No, but high systolic pressure is not there, but the pulse pressure is wide.
Yeah.
That is the problem there. How do you explain that? That's why I said, pulse pressure represents stroke volume. If you're
Yes.
telling that the AR is only mild, then pulse pressure also has to be not widened.
Yeah.
What is the diastolic pressure here?
50, sir.
How did you measure the diastolic pressure in this patient?
Rodko's 4th or 5th, or you
No.
mentioned both.
No. They are not even checking with this Korotkov
Just give them a
method.
clue, sir, so that they can answer quickly.
It was the Korotkov 5th sound only, sir.
So it's better to mention both Rodko's 4th and 5th, because 5th cannot be reliable. Absence may be 0.
Yeah.
So just softening may be fair enough as a diastolic. Anyway, there is an error, but it doesn't matter. But you should know this. Of course, you should also say that once you have said there is pulmonary hypertension, make sure that there isn't any right-sided murmurs. What are the right-sided murmurs you will look for?
The right-sided, we can look for the tricuspid regurgitation murmur, and also because of the pulmonary artery hypertension, we can get an ejection systolic murmur in the pulmonary area, and also an early diastolic murmur in the pulmonary area, sir. The Graham scale murmur if severe PH.
Commonest will be tricuspid regurgitation.
Tricuspid
You
is
may
the-
be able to easily make out because all others are diastolic murmurs. Systolic murmur only would be in the lower area. You should use some maneuvers like inspiration and see if there is a murmur, correct? Because patient has heart failure, isn't it? Okay. And of course, basically you may look for tricuspid stenosis because mitral stenosis is there. Mitral stenosis, tricuspid stenosis is a common association. What is the association between mitral stenosis and tricuspid stenosis? clinical and subclinical or pathology.
Mostly echocardiography.
Yeah, most of it is echocardiography.
Yeah.
Yeah, it's around 5% significant organic stenosis with mitral stenosis. You should
So
always
this,
just make sure that you don't miss all those. I think, is there anything else?
nothing. I think we'll move
Okay, I think let's go to the,
diagnosis.
Diagnosis: acquired valvular heart disease, a rheumatic heart disease with severe mitral stenosis with moderate aortic regurgitation, with severe PAH, severe pulmonary venous hypertension with features of left heart failure, currently in New York Heart Association class 4, in sinus rhythm with no evidence of acute rheumatic fever or infective endocarditis.
What is your evidence to say moderate aortic regurgitation?
So the Hill sign was 40, sir.
I think you should go back and read Brownwald. He says categorically dismisses Hill sign should not be used for evaluating the severity.
he says only pulse pressure.
Yeah.
No other peripheral sign. You don't have to waste time at DM level to enumerate those 14 peripheral signs of aortic regurgitation. Okay. But rather, you should find out whether the aortic runoff is peripheral or central, right? Like as you said, high volume, volume output state and all that, anemia, teratoxicos rarely beriberi, but I'm sure people have seen beriberi, especially pregnancy, due to very strict dietary controls and all. I think in Hyderabad, they are recorded.
Yeah, we have.
So, I think so. So we'll go to the next step.
Yeah.
So mitral stenosis, yes, okay. I think we quite agree with you, except that the reason for moderate aortic regurgitation, I would quite agree with you that low diastolic pressure in absence of any other causes of aortic runoff or high output state is certainly an indicator of moderate AR. I think so.
Go ahead. Yeah.
Sir, X-ray, sir.
Yeah, good.
Sir, this is the chest X-ray.
Shall we ask the
view.
student panel also to participate?
I just wanted to answer two questions. Is there evidence of pulmonary arterial hypertension here?
Yes.
Yes or no? Pulmonary arterial hypertension.
Yeah. I think KEM can take over.
Anybody?
What are the features of pulmonary hypertension, basically? Yeah.
Sir, the main pulmonary artery and right pulmonary descending artery are seems to be enlarged, and there is pulmonary plethora also seen.
Pulmonary plethora? No.
No, be careful.
Pulmonary plethora is not there. You mean to say upper lobe venous distension is there. That is not same as pulmonary plethora.
Just see the lower segment pulmonary arteries and the upper segment pulmonary is vascularity. See so much of difference.
So what will be the LA pressure here based on the X-ray? What will be the LA pressure based on this X-ray? Am I audible?
Yes, sir.
Yeah. What will
KEM can take over. KEM, please join us in the discussion.
Based on
I already said there is pulmonary venous hypertension. The patient has orthopneas, KNDs. What would be the pulmonary wedge pressure, isn't it, sir?
Yeah. What is the normal LA pressure?
Sir, 12 mmHg, less than 12 to 15 mmHg.
So with the upper
lobe,
lobe,
talking about LV EDP. EDP, yes, 12 to 15. 15 is cut off for the current diagnosis for diastolic. But LA mean? Does LA mean and LVEDP correlate? What does LA mean correlate with?
LA mean pressure correlates with what pressure in the
what component of the LA mean pressure?
In the absence of any valvular heart disease, let us
LVDP and pulmonary capillary wedge pressure.
Sorry?
No, I'm not talking about. I'm not talking about wedge pressure. I'm talking about the LA mean pressure, right? Does it correlate with EDP or something else on the left atrial tracing? Very important to know this, because you see in hypertension, hypertrophic cardiomyopathy, you have LVEDP of 40 and your LA mean may be just 20.
Then does it correspond to pre-A LVEDP or
it is called the
post-A?
diastasis pressure, right? Where the LA and the LV pressures in diastole tend to equate. Other than mitral stenosis, they tend to equate. And that is the one which actually tells you the LA mean pressure. Though in most of the conditions, the difference between LV, ADP, and LA mean pressure are not very significant, but there is significant diastolic dysfunction, hypertrophic cardiomyopathy, and HCM. There is a marked difference between LA. This is what is always highlighted in diastolic heart failure.
Yep.
The LA mean pressure cannot be more than 12, let me tell you. Right?
Is there a cardiomegaly or no cardiomegaly?
No.
Yeah, clinically, she said cardiomegaly 6 phase. So obviously, it was also LV type. So obviously, it has to be due to.
What other chambers of the heart are enlarged in this X-ray?
Sir, RV enlargement is there, we can see.
Sorry,
And
did you
we
say
can also
RV?
see
Did you say RV?
RA, sir, RA.
RA.
Okay.
And possibly LA. And possibly there are double shadows also seen. So
Possibly LA enlargement.
LA
You can see the slaying of the carina also, sir. So possibly yes.
Yeah, there
LA
is
enlargement.
clearing of the carina. What about the LA appendage shadow? Is it not there? It's below the pulmonary artery segment, there is an LA appendage shadow. Right? It is usually seen only in rheumatic mitral stenosis, in other conditions of. Right. So I think X-ray is fairly clear to you, isn't it? Your diagnosis is quite correct. There is LV enlargement, so aortic regurgitation. There is pulmonary venous hypertension with LA enlargement, which is all due to probably mitral stenosis rather than LV dysfunction due to aortic regurgitation. That is why I asked you a long duration of stable symptoms of dyspnea typically is in a rheumatic valvular mitral stenosis. Because symptoms in mitral regurgitation, aortic stenosis are due to LV dysfunction. In mitral stenosis, it is not due to LV dysfunction. It is due to
the pulmonary hypertension, sir.
Pulmonary venous hypertension. And there are many compensatory mechanisms over these 10 years which allow the pulmonary venous hypertension to be controlled. Chronic pulmonary venous hypertension. What are the mechanisms? Do you know? Just 1, 2, 3, 4. You understood my question, isn't it? The hemodynamics of a long duration of mild symptoms, onset of symptoms. So symptoms of onset is there, and then 10 years there has been not much progress. That is very typical of mitral stenosis compared to other distal valvular lesions, either mitral regurgitation or aortic regurgitation, aortic stenosis. You can't tell, otherwise you can read it up. What are the compensatory mechanisms?
Because there will be the pulmonary vessels, the capacitance also increases, sir, because of the raised PVH, and also the wall also becomes thickened, sir.
I'll tell you one thing. It improves the lymphatic drainage of the lung. It actually causes alveolo-capillary membrane thickness, right? Then pulmonary artery hypertension really causes some pulmonary arteriolar constriction, correct? That also reduces the forward output. Pulmonary regurgitation, tricuspid stenosis, tricuspid regurgitation, all reduce the forward output. All these allow the patient to be mildly symptomatic with effort dyspnea in mitral stenosis. You get my point? And of course, there is rarely you can say it's opening up of the pulmonary venous to systemic venous collaterals. So that pulmonary veins can decompress into the systemic. So these are some of the reasons why mitral stenosis can often have a long history. That's why I asked you when you said 10 years. Palpitations actually came much later. So primary valvular lesion or volume overload lesion would have been low in the diagnosis. Okay. Sir, anything more to add? Otherwise, we'll go to the ECG.
I think we should go to ECG.
Yeah, good.
Okay, tell us, is it fitting with dominant which ventricle is increased?
Dominant looks like the aortic regurgitation looks like the dominant.
No. Dominant
ECG.
LV or RV?
LV, sir. There are tall R waves in V5 and V6 with small narrow Q waves in V5 and V6 with deep S waves in V1 and V2. Such true of LV volume overload, sir.
LV volume overload is not just tall R waves, something else.
Something else.
Narrow Q waves are there, sir.
Good Q waves in V5, V6, isn't it?
V6,
Good Q waves. Unlike aortic stenosis or hypertension, In
Yes.
nitric regurgitation, mitral regurgitation, you will get good Q waves, right?
Yes.
Also,
So
you should highlight.
your AR,
For
your
that LV dominance, the axis is
what is the QRS axis here?
QRS axis.
60, sir.
Yeah, so that is a little odd, isn't it? Usually,
Yes.
you get a leftward axis in the
Yes, sir.
LV hypertrophy. So that also you should suspect that there may be some RV hypertrophy, which are not evident on the
Yes, sir.
electrocardiogram.
It's difficult to diagnose biventricular hypertrophy on electrocardiogram. So whenever you find an unusual things like LVH with the rightward axis, that should be the criteria. Okay, go ahead. Is there a
Yeah.
left atrial enlargement in this ECG?
Yeah, of course. That's the another thing. What are the reasons why you should suspect left atrial enlargement in this?
Because associated mitral stenosis is there, sir.
No, ECG.
Biphasic P waves in V1, sir.
Is there any evidence of left
enlargement.
atrial enlargement on the ECG? What are the
What are the
ECG
things-
criteria for
What are
left
the
atrial?
things you look for left atrial enlargement in the electrocardiogram?
Sir, widen increased duration of the P wave more than 120 milliseconds in the lead 2.
Okay.
Or
One is, of course,
biphasic,
increase the duration of the P wave, then the
biphasic
ratio of the
P
P wave to
waves
the
in the-
PR segment. Yes.
Yes.
And
Biphasic P waves in lead V1 with the downward negative component more than one small box or 40
Okay.
milliseconds.
okay, good. And one more. Bifidity of the P waves with the bifidity separated by at least 40 milliseconds. So these are the things you should look for. All of these are borderline in this case, maybe except that P duration is a little longer and P to PR segment ratio favors left atrial enlargement. Okay. So
Go ahead.
yeah, go ahead.
Next. Yeah.
Sir, this is the echo, sir.
I give a running commentary.
Okay, sir. This is the parasternal long axis view echo. It shows thickened and calcified mitral leaflets, both the anterior and the posterior mitral leaflet, with diastolic doming of the anterior mitral leaflet is present, sir. The LV cavity appears to be dilated and the LA also appears to be dilated, sir.
What about the RV?
Sir,
What about the RV, right ventricle?
RV, it's not dilated or no hypertrophy is seen.
No hypertrophy. So you said severe PAH. And
what about the
you
aortic
said
valve?
that you
Aortic
said there is
valve also?
calcification. Calcification of the, what is your basis to say calcification?
It is hyperechogenic, sir.
So
Okay, so you can
hyperechogenic,
say hyperechogenic rather than calcification. Hyperechogenic. Very dense
And
echo. Yeah.
Yeah.
It would indirectly say there may be calcification. Right. What about
and
aortic valve?
aortic valve, sir.
aortic wall.
Sir, aortic valve also, it shows thickening with the hyperechogenicity, and we
Okay.
can also see that the right coronary cusp is prolapsing, sir. There is probably non-coaptation, sir.
I'm not so sure, but
There is some that prolapse is not there actually.
probably the calcium is seen.
Yeah.
Okay.
What is the normal thickness of the leaflets?
Sir, it varies age-wise, sir. So less than 20 years,
No, this is a 50-year-old lady, right?
it should be less than 4 millimeters, sir.
Normal.
Yes, sir.
Okay, go ahead.
This is the parasternal long axis view with the color Doppler, sir. It shows regurgitation in the aortic valve, sir, which occupies around 50% of the LV outflow tract, sir, and it also shows mild mitral regurgitation, sir.
Are these parameters valid in the presence of multivalvular heart disease?
No, sir.
So what is the load independent markers of valve regurgitation?
Sir, we have to look at the quantitative markers, sir.
No,
like
load.
regurgitant volume, effective regurgitant orifice.
No, they are not. Kindly listen to the question. Tell us the load independent markers of severity in valvular regurgitation. What you are telling, regurgitation volume and fraction, is load dependent.
Vena contracta, sir.
Full load.
So what are the two? There are two markers which are independent of the loading conditions. It is very important for you to know that. What is vena contracta?
The highest amount of separation between the two leaflets.
Is it a
possible.
no? Is it a anatomical of the leaflet or something else? You said leaflet separation. You have said. Is that vena contracta, or is it referring to the vena contracta refers to the blood flow or leaflet separation?
Blood flow, sir. Narrowest part of the flow.
So vena contracta, what is the other parameter which is independent of the loading conditions apart from vena contracta? Both are interrelated. What is EROA, effective regurgitant orifice area? These two are the two independent parameters of valve.
What are the parameters on these two to say aortic regurgitation is severe? Vena contracta and regurgitant orifice area. These are all standard things, no?
Vena contracta more than 6.
Yeah, KM, take over.
Sir, more than 6 in case of.
I can't hear you.
More than 6?
More than 6.
Regurgitant orifice area.
And vena contracta.
And vena contracta.
Vena contracta more than 6. Sir, vena contracta more than 6 mm in case of severe AR.
What about MR?
7.
Why it is more for MR? Why it is less in AR? Vena contracta. Why it is more in MR and less in AR? Any idea?
Because originally naturally the mitral valve area is larger as compared to the.
No, they got nothing to do with mitral valve area. MR is systolic or diastolic?
Systolic.
Systolic. AR is?
Diastolic.
So which one is larger, longer?
Systolic, sir.
Systolic is longer than the diastolic.
Diastolic is longer, sir.
So diastolic is longer. So for the same orifice area, if the diastole is longer, it leaks longer. It leaks much longer. So that is the reason why that effective regurgitant orifice area and vena contracta are smaller as compared to the mitral regurgitant orifice areas.
EROA more than 0.6, sir. And
EROA 0.6?
VRA more than 0.3 and vena contracta more than 0.6 is as true of severe AR, sir.
Okay. So for severity, any other simpler method about all these calculations? Assuming that
end diastolic or holodiastolic flow reversal, sir. On aortic from the suprasternal view, we can put a mode and
qualify that statement. You should qualify that statement. It is a hollow diastolic reversal of the flow with what should be the end diastolic velocity?
This end diastolic velocity more than 20 centimeters per second, sir.
Yeah, that should be there. That should be there. Otherwise, it is not valid. Okay, go ahead.
Okay.
This is the M mode, sir. M mode showing
identify the various components of M mode on the mitral leaflets. Systolic component is called ERB. Some words are there, na? A, B, C, D, E, F.
Yes, sir.
So systolic represents what? Which letters? What is the letters given?
A, B, sir.
No. A is atrial contraction, you know. CD, that is CD. CD is the systolic component, single line. Systolic component, yeah. E is the first initial portion, early. E is early. A is atrial contraction. So EF slope and A. I think people have forgotten M mode echo. What is the abnormality here? Is it normal mitral movement or abnormal mitral movement?
Abnormal mitral movement, sir. The paradoxical motion of the posterior mitral leaflet is seen, sir, and also the EF slope is decreased, sir.
Okay. No. Why do you get a paradoxical movement?
Because of the thickened reflex and during the diastole we get the
No, that is not correct.
Commissural fusion.
movement, sir.
And being AML being the more dominant leaflet, it will pull the PML towards.
It is commissural fusion. It is commissural fusion that causes the posterior leaflet to move along with the anterior leaflet.
It's very specific for valvular mitral stenosis.
Yeah. Okay. What about the pattern of movement of IVS? Can you just go back to the previous one? Yeah. Is it normal or abnormal?
Normal, sir.
Normal. Okay.
It looks normal. What about the E-septal separation? And what is the reason for that E-septal separation being a little increased?
Because of the LV enlargement, sir.
No. Is it valid?
Not LV enlargement.
No. Is EPSS, is it valid in the presence of a mitral stenosis?
No, sir.
So,
because of the thickness of the valve, the movement will be restricted. So EPSS will always come more, sir.
So you should never use EPSS as a sign of a LV dysfunction when there is a structurally abnormal mitral wall. Or even in ARs, secondary abnormality of the mitral leaflets.
Yeah, that's right.
So EPSS should be measured only when the mitral wall is normal and aortic wall is normal. Then EPSS represents what? What does that indicate? Let us say EPSS is 20 millimeters. What is the normal EPSS?
Less than 7, sir.
7 what?
Yeah, 7 millimeters.
7 mm.
7 mm. So if the EPSS is 20 millimeters, what is the inference you get out of that?
Sir, two things, sir. LV cavity is dilated, sir, and the anterior wall AML motion is also because of this anterior AML is not able to move.
You're not talking about mitral stenosis. Sir is asking E-septal separation is 20 millimeters. In absence of mitral stenosis, normal mitral valve. What are the possibilities?
What is the
LV dysfunction and LV dilatation?
LV dysfunction and?
No, what is the expected EF?
And aortic regurgitation, right? Aortic regurgitation also reduces the E-septal separation. Very severe aortic regurgitation because the aortic regurgitation often is towards the anterior leaflet, isn't it? You get a flutter, but that will be the indirect. Okay, let's go to any other.
Any other
function looks okay.
Okay, so what is the conclusion here? To the student panel?
It looks like severe rheumatic mitral valve stenosis along with aortic regurgitation. But
aortic regurgitation is mild, moderate.
Sir, as the jet width is more than
No. As I said, in multivalvular heart disease, hemodynamically independent parameters should be used. So you need to repeat the echo properly and then see what is the vena.
There is a still picture of the regurgitating orifice, isn't it?
Yeah.
So you can measure it. It's around 2 millimeters, I think.
We need to do good evaluation of the aortic regurgitation. Otherwise, you may be doing injustice to the patient. Okay, go ahead. Assuming that the vena contracta is about 6 millimeters in this patient, what would you recommend?
The patient, if it is 6 millimeters, then it has to have severe AR, sir. So, and also patient has a mitral valve involvement also, sir, with severe MS. So we will.
No, we have not shown any data to show that it is severe MS.
Yeah.
This is a short axis view, sir.
Yeah.
Okay.
Across the mitral valve, it shows commissural fusion is there, sir.
And which commissural fusion? Which commissure is fused?
Yeah, good. Go ahead.
So the anterolateral commissure seems to be fused, sir.
Okay.
Okay.
And
You have to be
planimetry
careful,
shows
you have to actually see the cross section. Unless it's at the tip of the valve, you might actually miss some of these things. I agree with you. The anterolateral is probably more fused than the lateral, but there is calcification right up to the commissures, isn't it? Is it important?
The important from the therapeutic point of view. How does that?
Commissural calcification is a contraindication for
PTMC.
PTMC, regardless of aortic regurgitation.
Yeah.
Right? So severe aortic regurgitation, obviously, you will probably not go BMV alone or PTMC. Okay, next.
this is the apical 4-chamber view, sir.
Yeah, you can run it quickly now because we are looking at the right side. Probably there is no significant tricuspid valve lesion. RV is not dilated. PA pressures we'll have to see if either PR or TR. Yes. Next. Okay. Yeah, you can just read the gradient.
PHT is 252 milliseconds, sir. And the aortic valve mean gradient is 16, sir, with Vmax of 2.45, sir. And this is the TR jet velocity, sir. And then this is the flow across the proximal descending aorta, sir. It shows diastolic reversal is there, but then the M mode color Doppler shows that the diastolic reversal is not hollow diastolic, sir.
So it is not?
It is not severe AR, sir.
Yeah.
Okay. Yeah, your TR velocity shows. Can you just show the TR velocity? It's a good signal. Yeah. Around 3, isn't it? No.
Yes, no.
3 point, almost 3.5.
Just borderline.
So. Yeah. So how much will be the RV pressures?
RV pressures
JVP, with your JVP also you can take into account 10 millimeters or 8 millimeters over.
Yes. Around 55 lengths.
Okay, around 45. Okay, good. That's fair enough. Yeah. So there is some pulmonary hypertension.
Yes, sir. And this is the flow across the abdominal aorta, sir. Proximal abdominal aorta, sir.
Okay.
Yes, sir.
So you can tell us your final diagnosis and your plan of management very quickly. You got all the information in it.
Yes, sir. So she is a 42-year-old female with rheumatic heart disease, sir, with multivalvular involvement in the form of severe mitral stenosis and also moderate aortic regurgitation, sir. So for her, I would like to offer a double valve replacement, sir.
You didn't complete the diagnosis, no? You told about mitral valve. You said severe mitral stenosis. We agree with you, but there is a trivial mitral regurgitation, which is probably central and not significant.
Yes,
it is maybe part of a very fixed mitral valve or is in diastole and systole. Then moderate aortic regurgitation or moderate severe aortic regurgitation. No aortic stenosis.
No, sir.
Okay, and then come backwards. No? Pulmonary artery hypertension, moderate pulmonary artery, secondary pulmonary venous hypertension.
Yes, sir.
Yeah, and mild tricuspid regurgitation, and of course you already said. So, do you think this patient can have an isolated PTMC in view of the constraints of surgical opportunities or needing double valve replacement?
Sir, isolated PTMC would not be preferable for her, sir.
Okay.
Because once we open up the mitral valve, again the preload will increase and the AR also might, again, it will go up. It might worsen, sir.
Yeah, basically the valve, if you look at the Wilson score, I don't think it will be more than 12 to 14, isn't it?
Yes, sir.
Both commissural calcification as well as leaflet calcification with very less mobility.
Yes, sir.
Would be generally a contraindication for
PTMC.
Obviously, aortic regurgitation is going to be an important criteria for your decision making. While to moderate, people would still say, why not just do a mitral valvotomy and follow up?
Yes,
but
sir.
in this case, I think that option is not there. What do you think?
What does the guideline say? Suppose if the mitral stenosis is severe, aortic regurgitation is moderate. what do the ACC/AHA guidelines say about tackling of the aortic valve?
Sir, if the valve anatomy is favorable for a PTMC, sir, then
No,
we
no.
will
Let us say valve anatomy is bad. You are going to do mitral valve replacement. Okay. Regarding the aortic valve, we have decided it is moderate aortic regurgitation. So, according to the guidelines, do you think we should leave the aortic valve alone?
No,
Or
sir, we have to replace it.
We have to replace. They should go for DVR.
DVR. Okay. What is the surgical mortality in patient with DVR?
Around 9%, sir.
Mm-hmm.
And it also depends whether the patient has LV dysfunction or not also, sir.
No, but was there any LV dysfunction here?
This patient did not have any LV dysfunction, sir.
Yeah, we're talking about this patient. So what kind of valve would you like to say, would you like to have in this patient?
Because she's only 42 years of age, sir, so I would prefer a mechanical valve, sir.
Okay, tell us the names of the mechanical valve with double discs.
With double disc, we have this bileaflet we have, and the tilted one also we have, sir. Carbomatic we have.
What is the names of the bileaflet? Mitral
We
valve.
have St. Jude's we have, sir.
And
then we have Carbomedic we have, sir.
Mm-hmm. So go ahead. Is there any valve wherein the need for anticoagulation?
We have the latest Onyx valve is also there, sir.
Mm-hmm. So what is the projected advantage?
So they say that they claim to be that the need for anticoagulation is low, sir. We can maintain the INR of around 2.5 for the first 3 months, and then we can put them on lifelong oral antiplatelets, and then maintain the INR of only 1.5 to 2, sir. So the less need of anticoagulation, sir.
But less intense anticoagulation.
Yes, yeah.
Okay. Dr. Tarakan, any other?
No, it's quite okay.
It's quite okay, yeah. Okay, I think we will ask Hari Krishnan to wind up.
Thank you, Tharayan sir and Sagar Rao sir for this wonderful discussion. I think the presenter and the discussions did well. So thanks to them. And Arun, Dr. Ajay. Dr. Ajay could not.
Yes, I am
he had some other engagement.
I
So I
just
think he
came
joined
from
late.
the
And
India
Dr.
Wall.
Amit. Okay, that many meetings are going on. Dr. Amit also could not join due to some personal emergency. So thank you everyone, and over to Arun for the vote of thanks.
Thank you, sir. I think we had a fabulous session today, and it was wonderful to have the proceeding started off with Dr. Noshin Reza's presentation on cardiac myosin inhibition and hypertrophic cardiomyopathy. That was and the discussion that followed after that also. I think it was wonderful. I believe all of us benefited from that excellent discussion. I should thank all the panelists and all the attendees for the active participation in the discussion as well. I should thank the both teams, Negrams, Shillong, Dr. Preeti, you did very well. I thank the faculty for the training as well. And as already mentioned by Chopra sir, I think you've been doing, the team has been doing very well from there, from the Northeast, and also the team from KEM Mumbai, very well discussed as well. I should thank the examiners, Dr. Tharagan sir, Dr. Sagar Rao, Dr. Ajay Mahajan, and Dr. Amit Malviya for leading this discussion forward. This has been the 5th year and succession that we've been hosting this set of events, and this has become a major affair, and it's being telecast worldwide now. And we've teamed up with HFSA and we have faculty joining us every alternate month for the discussion from there as well. This the whole credit goes to the HFAI fraternity, Dr. Chopra sir, Dr. Venugopal sir, Dr. Harikrishnan sir, for having this sort of an event time and again. And I should also thank Dr. Sajan Ahmed, who is also worked hard behind the organization of this event. We are supported by an unconditional grant from Sun Pharma, the Coronas division. I should thank the Sun Pharma team. Also, Netcast and the other Sumita and others from the HFAI who worked behind the organization of this event. We'll get back next month for the next edition. And I thank both the teams for the active participation tonight. And we'll get back on the second Saturday next month for the next month's event. Over to Harikrishnan sir for the final words.
So thank you, Arun. I think we had a good session, and we thank all the participants, faculty, and also Hallmark Events and Sun Pharma for the support. So thank you and good night. And we will have the next session on October 11th, second Saturday. I think Negrims will be discussing, and we will have one more institute who will be presenting, and one talk will be on statistics, something on statistics, which we will announce in another week's time. Chopra sir, any final comments? And
No, thank you. I think it was a wonderful discussion. We all enjoyed it and look forward to the next issue.
Thank you.
So thank you and good night, and thank you. Bye.
Thank you. Good night.